Thanks everyone for joining. Just as a reminder, as we're diving in here, this webinar is recorded and will be available to everyone who had registered and attended afterwards. We will be doing a Q&A session at the end, so please feel free to submit your questions at any time as Julie and I are talking, and we will definitely leave time for Q&A at the end. All right, everyone, welcome to How Design Thinking Revolutionized Nurse Retention at Vidant Health. That's what we'll be covering today. And what we're going to be covering is how, and we're going to be hearing more about how Vidant Health retains permanent nurses and their approach to it as well. My name is Iman Abuzaid. I'm an MD by background. I've been in healthcare technology for the last 10 years of my career. I am the CEO and co-founder of Incredible Health, a career marketplace for permanent healthcare workers. Incredible Health is one of the fastest growing hiring marketplaces for nurses today. And hospitals and health systems use our technology to hire nurses, particularly in permanent and experienced nurses, in 20 days or less, and normally takes 80 days or longer. What we do is we flip the script where hospitals and health systems are applying to nurses instead of the other way around. So joining us today is Julie KennedyOehlert. She's the Chief Experience Officer at Vidant Health. She's also a nurse. Vidant Health is a 8-hospital health system in Eastern North Carolina with more than 13,000 employees and serves 1.4 million people. Julie holds a doctorate of nursing practice in health innovation and leadership, and she leads patient experience, team member experience, and workplace well-being at Vidant Health. This also includes experience marketing and communications, hospitality, interpreters, and even food service and environmental services. And yeah, Julie is a nurse by background as well. Thank you so much for being here, Julie.
Oh, it's so good to be here. Hi, everybody.
All right. So as a reminder, we are recording. Let's dive into the agenda. This is designed to be interactive. Please feel free to ask as many questions as you like in the chat, and we'll answer them as we go along, and also set aside time at the end to answer questions. What we're going to be covering today is the state of the nurse labor market and what's happening with nurses today, because it does keep changing and it's a very dynamic market that we're all operating in. Second is how to apply design thinking to nurse retention and nurse well-being, which Julie will go through in detail. We're going to be covering the top reasons why nurses leave their jobs and how Vidant addresses these. And then we'll go over how Incredible Health helps with nurse retention and with nurse hiring as well. And then we'll do Q&A. All right, let's do a quick market overview. Let's set the stage of what's happening in the market today. So we know that healthcare is the #1 employment sector in the US by number of workers and by dollars spent on the workers. It has been the #1 employment sector since 2018. 1 in 8 Americans works in healthcare. But we have a problem. We have a challenge in healthcare, that our demand on the healthcare system continues to increase as our population is aging. Of course, pandemics don't help. They are demand shocks on the health system. But the supply of workers has not kept up with that demand. And that includes the supply of clinicians, nurses in particular, but it's all clinicians. The supply has not kept up with the growing demand. This was the case before the pandemic, and certainly has been exacerbated by the pandemic. A few statistics to share, just some of the national data that we're all dealing with. We are on track to be 1 million nurses short by 2023. We are missing essentially 1 million nurses based on the demand that we have. The annual turnover for nurses has increased to 21%. Before the pandemic, it was at 18%. That was a national average. We have some health systems lower than this. We have some health systems higher than this, but the national average is currently sitting at 21%. Also, labor as a percentage of revenue continues to increase. So 48% of revenue is being spent on labor. That does continue to go up quarter over quarter. And that's not just from travel nurse costs, that's even permanent nurse costs continues to increase as their salaries increase, signing bonuses increase, retention bonuses increase, and so on. That's what happens when you have a skilled labor shortage. You have to spend more on the labor. And then we're also seeing an 82 days on average, days to hire, days to fill for permanent nurse roles, particularly nurses that are specialized in experience. And the pandemic has made many of these stats worse. The other thing we wanted to just set the stage on is what are the top reasons why nurses leave? This is data from the Incredible Health Marketplace. For every, we have hundreds of thousands of nurses in our marketplace. Each and every one that creates a profile is asked, hey, why are you leaving your job? Why are you starting a new job search? By far, the number one reason is career advancement. I'm looking to grow my skills. I'm looking to cross train. I'm looking to move into management. I'm, whatever it is, some form of career advancement is what they're looking for. That's the most common reason. Second most common reason is flexible schedules. Hey, I'm looking for a better schedule that fits into my life better. Many nurses are caring for children. They're caring for older people, for their elderly family members, and they just need more flexibility in their lives. The 12-hour, 3-day shift does not work for everyone. And looking for more flexibility. The third reason is something to do with geography. They're trying to reduce their commute at that time, or they're actually physically relocating to a different city. And then the fourth reason is compensation. They're looking for higher pay. I think many of the nursing and hospital and HR executives we work with focus a lot on number 4, and they think it's all about the pay, when it turns out actually that's reason number 4. Numbers 1 through 3 are more prevalent in terms of the reasons why nurses are leaving organizations. All right, so let's start with just hearing just the state of the market for Vidant Health. How has the pandemic affected nurse retention at Vidant, Julie?
I think it's probably the same as everyone on this call. Nurses are looking for other opportunities outside of clinical. Nurses are burned out. They're cutting down their hours. And I think what I hope comes out of the pandemic, of this thing that's going on with nursing, is that we think of better ways to manage our retention. Because I loved what you just showed, because compensation isn't the holy grail of us being able to retain great nurses that'll take really good care of our patients. So I think I would say our experience is the same, but I think we are trying very hard to approach this, not just thinking about compensation only, but thinking about well-being, thinking about environment, and then also thinking about role modeling. What else can you do in a health system besides just a bedside, a bedside nurse, which is probably the most important role that you'll ever have, but not everyone feels like they can continue there after the pandemic.
Yep, absolutely. So I know, Julie, that you've pioneered or you've implemented design thinking at Vidant Health, it's particularly as it applies to the problem of nurse retention. Would love to hear more about what does that mean? Just if you could help explain it for us.
I'm a big fan of design thinking, and so of course I have a doctorate in innovation, which is unique.
Yeah.
But what a great time to innovate. So design thinking is really a human-centered approach to innovating, and it's really anchored in empathizing with the end user, and then defining your problem, and then trying it, test a change, and refining it. And what's beautiful about design thinking is it includes the people that you're designing for. And so in this environment where people can feel like leaders are tone deaf because they don't really know what's going on, they don't know that they understand or feel what I'm feeling working on the COVID units, working in the ICUs, that this involves everyone. So I think it's a particularly smart thing to do coming out of the pandemic, is let nursing design for nursing.
Okay, so in this case, the end user is the nurse.
Sometimes the patient, sometimes the patient too.
Sometimes it's patient. Okay.
Yeah.
And could you walk us through sort of the framework or the steps or the stages that you go through to think about design, to apply design thinking to this nurse retention challenge that we all have?
Well, I think the very first thing is empathize for the end user. And sometimes we call that go and see. And so that means that you don't design or make a decision unless you've asked nursing. So you open up forums and you open up venues where the nurses can say, I don't think that's a good idea. I didn't think that was right for me. The other thing is nurses will vote with their feet. So if you do something and they don't show up, quit doing that. Do something that they show up in droves and go, hey, spot on, I really like this. So empathize for the end user is probably the most important thing for healthcare organizations to do right now. Listen to nursing. They know what they need. They know what they want. They'll help you if you listen. And then defining the problem, because sometimes we in healthcare design for problems, it's not even the real problem. And so
Mhm.
again, if you define exactly what are you talking about, what do you mean by well-being? What do you mean by resilience? I mean, we found out that our nurses don't really like that word. Resilience sounds to them like suck it up.
Yeah.
So we don't, that's not a word we use anymore, because they're like, they want to thrive. They
Mhm.
want to be committed. So again, that definition, and then just get every idea you can and
Yep.
try things.
Okay. So empathizing with the user, and listening, defining the problem,
Yep.
and getting I
Ideate and brainstorm, and then just try it. Try
brainstorm,
things.
right? So then brainstorm the solutions, then test them. So try them.
Yep.
And you mean when you try them, you roll it out to the entire health system right away, or do you just
No,
try it out in a
it's-
little
yeah.
pilot? How do you
Try
think
a little,
about
we
that?
call it a little test to change. We
Okay.
just try it. And it doesn't even have to be fully baked. You
Yeah.
can say, hey, this might work. Let's try it on 2 units, or let's try it at the front desk, and let's see how it goes for a couple days, and let's learn from it. And I actually think that healthcare people like this because they can be involved, and because they can let things evolve, that they design something that then they really like because they were a part of it.
Got it. Okay. So then the initial tests roll out, and then there's some things go well, some things don't.
Yep.
And what happens at that point?
And then if it works well,
Yeah.
then you start to build how you want to scope it.
Okay.
So if it works really well on a couple units, and it's, and you've iterated it till it's looking like, oh, we got some great results, the nurses really like this, like we've done some new roles, then we start to think about how we're going to create it for scope. And then you start the work of scoping it, putting policy and practice in. But we don't do that till after we play quite a bit, because we need nurses to help us in the design for anything, really.
Got it. And then after that, you scale it.
Yep.
Yes, you roll it out further.
Yep.
Okay. It's actually very similar to the process we use for product development here at Incredible Health.
Yeah.
Design thinking is used extensively in software
Yep.
development. Would love to hear, a specific example of a solution that you found using this process.
So really, this is really interesting. So we were standing up our mega vaccine clinic, and we were doing about 2,000 vaccines a day. This was during high COVID time, social distancing, don't want to go to the grocery store.
Yeah.
And the team members were showing up to volunteer at the huge mega vaccine clinic after working. And they didn't want boxed lunches. They didn't want fast food. So we stood up a Minimart. So we literally put in a Minimart where they could come in and choose their food. They could pick hot food. They could pick cold food. They could pick things out of the refrigerator, and then they could just go pick it up when they wanted to and take it to their little social distancing area and eat. What a difference that made. And then if they wanted to, they could take stuff out of the Minimart, and we made it all free, the Minimart, to take home with them because they were working so much that was healthy food for their families. And we really, I wouldn't have thought of having a Minimart in our COVID vaccine clinic, but the nurses right away and the other people that worked there were like, it's not going to work for us to have pizzas delivered and things. It's not good for us. And so there's just listening, and then, standing up something that people really loved, and it made the experience for them much better.
Got it. Okay. That was an awesome example. Would you be able to give us another one just to make it really clear to the audience how you applied the design thinking?
Absolutely. So I think we're probably going to talk about this eventually, but we stood up Tranquility Rooms when the pandemic hit, which is spaces where the nurses could go. They had to socially distance. It was interesting, but they had little stations where they would maybe have a place to watch funny movies or watch nature. And there's maybe 15 stations. Well, we figured out really quickly that they couldn't leave their units to get to these beautiful Tranquility Rooms. So we boxed up everything, moved them up to the units, moved them in little spaces next to the ICU. And then they were like, what we really want? We want massage chairs. And we're like, massage chairs? That's a great idea. I didn't think about that. So then we got with our foundation and delivered massage chairs, right where they could leave their unit and get massage chairs. And then somebody said, why don't I have some things I can take with me? And we're like, great. So then we did Tranquility to Go, which were like little lavender balls that they could put in their pocket, little things that they could take with them. So we wouldn't have iterated that without their constant feedback. Because initially we thought, a Tranquility Room down in the first floor would be fine. We're a 1,000-bed academic medical center. The nurses can't get to that. So again, just listening and ideating, beta testing it, and have an empathy for your end user.
Got it. Okay. So let's go deep into this topic of well-being and burnout, which is, it's been a big theme of the pandemic. I mean, honestly, it was a challenge long before the pandemic too.
Yeah, absolutely.
And so if we go deeper into the reasons why nurses leave their roles and how to address these issues, according to, a lot of our data, as well as published data, that, there's a huge subset of nurses that leave because they're burnt out, because they want a healthier work environment, because they want career advancement opportunities, because they're looking for a better schedule. And so would love to hear a little bit more about, like, if you could give us an overview of the nurse well-being programs at Vidant Health, because it sounds like you have a very robust set of solutions that you put in place to address nurse well-being.
So it's interesting because what you just said is true. For well-being, one size fits one. Not everyone's well-being is the same. So if organizations think that they can have a blanket of one or two things, then they're going to miss a lot of people. Burnout and being able to thrive is really quite individualized. So we had this, she's a nurse leader at our academic medical center, and she was in her D.N.P. And right when the pandemic started, she said, I'm worried about the nurse well-being. And I said, what should we do? And together we just created a variety of offerings that the nurses could respond to that would meet their unique needs. And so one of the things that we did is we partnered with EAP, because a lot of nurses won't go to EAP, even if they have great resources, because they want to be strong and they don't want people to perceive that they're not, cutting it. And so we designed these well-being pop-ups, or a pop-up, it pops up. And we made these little packets that were like spa kits that had the things that you can put over your eyes that help, because they had their faces with the masks would be sore, and it had chocolate and it had little well-being hints in it. And we'd say, hey, you want these cool spa kits? And they'd be like, we love those. And we'd say, come into the break room. And then EAP would there and they'd be like, hey, how are you sleeping? How's it going? And it was such a safe environment where we could get EAP resources to the nurses, and they felt comfortable and they felt like it was authentic. We also set up listening circles where people could just request a listening group where they could talk about their experiences. We had an EAP person there, and we also have amazing medical director that's an integrative medicine doc, and she would go as well. So they could have listening circles. These things are things they could ask for as well. We did the Tranquility Room. We also did a lot of what we called spirit lifting, where we would send food to the units. We would send things that we thought it would help ease the nurses during the day. A lot of them were designed for people to ask for, not like you have to do this. And so people would say, what do you have for us in the unit? We'd say, we have listening circles, we have well-being pop-ups, we can send things to your unit. And what we saw is people started leaning into that and really loving it. Now, there was a couple of things we did. Remember when I said one size fits one, that people didn't respond to, and then we didn't continue them. We did think that the nurses would like open mic, like StoryCorps, where they could talk about their experiences. They didn't.
Okay.
We set up a beautiful room. We set up a mic, and they're like, yeah, we're not doing that. But then they said, what we would like? We would like the marketing and communication team to come and do video and photos of us, because we want to tell the public how to be safe. So then that's what we did. And so we went up, and if you look at our website, you'll see these beautiful pictures of our nurses begging people to please be safe during the pandemic. So again, just listening to the nurses and listening to all our team members, and really trying to respond to what they think will help them, get through this really hard time.
Got it. What does EAP stand for?
Oh, sorry. That's an employee assistance program. That's like,
Great.
Sorry. So employee assistance is a place in healthcare where sometimes you send people, maybe, I don't want to say against their will, but you refer them there. But EAP has like well-being resources. They have, counselors. They have help with sleep, anxiety. And so we included them, but not in an overly structured way, so that people could reach out and have those resources if we wanted to. The other thing I think that was very interesting that we did is we did mindful meditations, and we had all the leaders do them, because we knew that the nurses needed to find peace, but we wanted to role model it for them. So every Monday, an executive would do a little 5-minute mindful meditation that the nurses could use to start meetings. They could use to start their huddles. And we just put those out there. And what we found is people started using them, going to the website, finding a little piece, using those mindful meditations. Not for everybody, but again, trying to do things that would meet the different needs of what the nurses needed in order for them to feel like they could get through another day, another week.
Got it. And so what would you say is the most of because your team implemented a lot of different things, which is fantastic. Some worked, some didn't. What would you say was the most impactful well-being program that you implemented?
So I think what we're doing right now, we just finished a test to change, is going to be the most impactful thing that we've worked on with nursing in my career, really. Because when we're past the fear and the crisis, and now we kind of know how to deal with the pandemic, but we have a shortage. We did a test to change on a new role called an experience coordinator. And this is a non-clinical person that actually helps the nurses with non-clinical patient needs. And this is one where you're designing for the nurse, but it'll impact the patient. And these were experience coordinators. We designed the role, we put them on 3 units, a single person, and partnered them with the nurses, and they would really just manage and help coordinate the non-clinical needs of the patients. And the nurses love it because, and this emergency room nurse said to me, she said, I want to get coffee for my patient. I don't have time because they work short. She said, and when I know someone is going to, it makes me less anxious. And so this became such a great test to change that we are actually implementing it in 24 units. And then each unit will have a non-clinical experience support person to help the nurses with those non-clinical requests that they want to get to, but they just sometimes don't have time.
Right. And so, I mean, that's a great example of, frankly, just taking stuff off of the nurse's plate, right?
Oh my gosh, yes.
And so what these experience coordinators, what are they responsible for?
So again, if you're using design thinking, you let the nurses say what these roles are going to be. And so we worked with the nurses. And so right now they do a variety of things. They ask the patient if they like their food, they might order them different food. They connect them via virtual with their visitors. Cause nurses were responsible for that too, right? So they say, did you visit with your mom? If she can't come, can we hook up with you on the iPad? They connect them with resources. Do you need pastoral care? Has someone come from EVS to help you? They give meal tickets. They also can help. One of the things that the nurses are really going to love is that they can help dress out the family members for COVID. Because, dressing out a family member to visit a COVID patient is a lot, right? Because they have to put on full PPE. And so they'll be trained to do that. They can go down in the lobby and get the family member. So they just do all of those little non-clinical things that the nurses really want to do, but they just don't have time. So it's like a nursing non-clinical extender of sorts. And then the nurses helped interview and hired the position too. So they knew, they were like, this is my partner here. I want this partner on my unit.
Got it. And this was part of the design thinking approach too. Like you was your team testing this new rollout in a couple units before rolling it out to the entire hospital? 3 units, and then
we tested in 3 units. The nurses loved it. The patient experience went through the roof. And so we repurposed some FTEs from areas that we thought we needed before the pandemic. We needed these more. And we started interviewing for experience coordinators for 24 of our units, mostly medicine units, and the emergency room.
Got it. Okay. So hospitals are, low margin businesses, and increasing headcount or creating new roles it's not a trivial thing. It's actually very challenging to do for any department and for any part of the hospital. So how did you get this approved? How did you get this additional headcount?
So interestingly enough, again, this is about being innovative, right?
Yep.
So that we're not fully staffed, and nor were people fully staffed before the pandemic. So if you don't have enough nurses, this is a very lesser expensive FTE. And we're not changing our care model, but this is a step into thinking about changing our care model. And then remember that patient experience across the whole nation is just trending down. And also, whether we like it or not, and we always have to think about engagement before we think patient experience is a lagging indicator, but you do have a cost avoidance if you don't hit your achievement goal for your inpatient patient experience. And so many hospitals pay millions of dollars when they don't hit their achievement threshold. And so we talked about that. And then we also talked about, as we want to get patients to come back, they have to have a great experience and they have to trust us. We need patience. And so this contributes to your brand and to how people perceive your care. And so those were all pretty heavy hitters for us to say, aside for just helping the nurses, this is a pretty good win. And so we repurposed several positions, and we will have in January, we'll have experienced coordinators to help our nurses. So we're really excited about it.
Got it. You'd mentioned earlier around getting feedback from nurses, right? The empathy and the listening piece, which is a key part of this design process.
Mm-hmm.
So how, I guess, tactically speaking, how do you get this feedback? How do you actually listen to nurse? I mean, there's 1,000 nurses at your health system, something like
More,
that. More, right? 9,000, is that what you said?
Yeah.
Okay, yeah. So that how do you listen to a group that big?
So, I'm going to just go old school. A part of empathy is go and see. We just talk to them. We just invite them to stuff. When we did the experience coordinator role, we just went up to the units and we said, you want to trial this with us? And they're like, well, that sounds interesting. And they're like, no, it won't cost you anything. We're just going to send somebody up that's going to help you with non-clinical needs. You're like, let's do it. So really old school. I want to say that if you have really, this is my opinion, but if you have really formal methods, it could feel inauthentic to nurses, or they feel like you're not really going to do anything anyway. And so we're pretty old school. Before the pandemic, we had done empathy salons and other salons, gatherings of people. So they kind of knew the Office of Experience. Because remember, I'm in the Office of Experience. We have great nurse leaders that are our CNOs and VPs of nursing. And we just asked them. We just would get with them, ask them, talk to them, just go where they are and ask them. And it sounds really old school, but it's safer to do it that way than try to think that you're going to get nurses to fill out a survey, because they're just going to probably roll their eyes at this point at you.
Right. Okay.
Hate to say.
Yeah. And so I'm guessing the formal ways was officially inviting them to something, having them fill out a survey. The informal, like, you and your team were just going to the units and just asking them directly.
Yep.
Okay.
Just talking to them.
Okay. Yeah. And that was probably faster too.
Yeah. We do have a innovation lab that we do with nurses. So we have a nurse innovation lab, and it's structured, but it's still, you just invite nurses and ask them what their wicked problems are and see if they can get solutions. And they respond to that. They like that too.
Okay. Awesome. All right. So let's go on to the topic of career advancement, education, mentorship. That career advancement is the number one reason why nurses leave. How could you help us could you share a little bit more about what Vidant does to support nurse career development?
It's an interesting question. And of course, that's one of our reasons for people leaving as well. But we actually hire nurses in a variety of non-traditional roles. So we literally have 8 hospitals. Half of the presidents of those hospitals are nurses. Our chief information officer is a nurse. Our VP of our medical practice is a nurse. Our head of home health is a nurse. So we see nurses as having a very broad leadership swath. I'm a nurse. I'm a chief experience officer. So I think when organizations are looking at development, they also have to role model that and show nurses that it's not just a trajectory up into nursing of leadership, that nurses can do a variety of things. And I think that role modeling has been amazing for us, both in us being very patient focused, but also in nursing kind of saying, hey, I can do any of these things. And we encourage them to apply. I was telling you that we have an administrator that was excellent nurse, and she used to work in the service lines, and she loves retention and recruitment. And now she is an administrator in talent acquisition, and she helps us recruit nurses. Who better to recruit nurses than a nurse? Yep. I mean, I just love that. Got
it. And then, look, I mean, you're also an example of a nurse in a non-traditional role. Could you just walk us through how you got to your role as chief experience officer?
Isn't it crazy? So, I was in the trajectory that a lot of nurses are in, right? I was going to grow up into leadership. I was an ER trauma nurse, ER trauma director. And I went into consulting for a little bit, and I started working with a lot of different leaders, and I kept thinking, my nursing brain can help with, being patient-centered, with understanding complex situations, right? Because nurses are trained to do these complex care plans. I just do a nursing plan for a whole health system, right? And so I just started applying for other jobs, and I was getting hired for a variety of other jobs. And I just said yes a lot. So if people said, when I was the CNE, they said, "Hey, do you want to run pastoral care?" I'd be like, "Yeah." "Hey, when you're the COO, do you want to run the gift shops?" "I do. I want to." "Do you want to run EVS and food service?" "I want all the scope," right? I want all the scope. And then what happens is that nursing then has that decision making that we really love, not only in our vertical, but across the health system. And so I would recommend, if people, think, "Oh, I want to try something else," do it. The trajectory for nurses, because we're so innovative and talented, isn't just into the nursing vertical. We have we had a nurse that I was working with. She's a D.N.P nurse, and she thought her trajectory was to CNO. That's all, VP CNO. And
Yep.
during the pandemic, she started working in the community, and she's like, "I love this." And so she just got a job as a vice president of social impact with our chief diversity officer. And he's like, "I love having a nurse. This is brilliant." I'm like, if you want something done, give it to a nurse, truly.
Got it. I mean, I think it's still, I think it's really cool, the approach that Biden has taken in putting nurses in executive roles. We know we work with other teams that have, they have different governance committees where nurses need to be present and members of those committees. But it's still pretty rare, honestly, for nurses to do non-nursing roles. It's becoming more and more common today. And so I'm glad that everyone attending can see you as an example of you're not in the CNO role, you're in the chief experience officer role, which is a non-nursing role, but you're very much still supporting nurses.
I love
and
that you
patient
said that.
experience.
I love that you said that, because that's kind of the drum I'm beating now, is that no matter where you work right now, we can support nursing for the nursing crisis. It doesn't matter. You don't have to be a nurse leader. They're busy. You can, our director, our administrator over pharmacy is thinking about how he can help with pharmacy techs. I mean, we can all help solve this problem. You don't just have to be in nursing to solve this really wicked problem before us, is that we don't have enough nurses.
Got it. And do you have any advice for us around how to get more nurses into leadership and into non-traditional roles too?
It's not just about compensation. So we are working on compensation at Vidant, and it's important, but the well-being of the nurses and also their environment is the stickiness. I again cannot say enough times that just compensation, I don't think, is going to solve this. I think nurses will stay where they feel valued and where they feel like their environment works for them, either, the schedule, the culture, and that's when nurses will stay, because we're mission driven, right?
Yeah.
And so I think sometimes we go right to compensation. And I think when nurses are suffering, and we don't listen and we don't listen and we don't listen, and then they're like, "Okay, pay me more because I'm suffering. Pay me more to suffer." And and then you still have higher paid nurses that are burned out. It's not the whole package.
Right. All right. Okay. So we've covered the topic of nurse well-being, of career advancement. Let's talk about scheduling. We said our data shows it's the second most common reason why nurses change jobs.
Yep.
And historically, hospitals and health systems have been so strict with nurse schedules. 3 days a week, 12-hour shifts, or we only have full-time roles available. We have no part-time roles available because that's not going to work for us operationally. But now, the end user, i.e. the nurse, is requesting more and more flexibility in their schedules. Love to hear sort of your thoughts on this topic and the approaches your health system has taken around this too.
Isn't this almost like a silly conversation that nurses just want to work different hours, and so whole organizations aren't listening? This goes back to letting nurses design for nurses. We have started to really look at different shifts and different flexible opportunities. I think the whole all of healthcare, I mean, thank goodness this is finally happening, because young mothers and young fathers didn't ever want to work the shifts that we gave them. And so I'm going to go back to, listen to the nurses and say, okay, if you don't want to work this shift, we can figure it out. What are the shifts that are going to work for you? It seems simple. I don't know why we have created so much rigid structure around something that's not that difficult to figure out.
Right. I mean, the reasons it is operationally challenging, right? To have a whole variety of different options, just from a hiring standpoint as well, just like, just staffing the units. So it can be challenging to implement, but at this point it's required, right? Like no one has any choice anymore.
I'm glad.
Yeah.
I'm glad.
Absolutely. Another innovative approach some of the health systems we work with uses combining flexibility with higher pay, right? So they've created, we've had, even before the pandemic, many teams had float pools, but now teams are creating internal travel agencies, internal travel nurses, basically. And these are nurses that are employees of the health system. And in exchange for flexibility, as in the nurse has to be flexible to work in any location, any unit, but there's more pay, more pay in exchange. So these approaches seem to be working well as well.
I love that. I mean, that's just another thing that organizations can do to listen to nurses and say, is this something that you're interested in? Try it. And if they have nurses that are interested in it, do more of it.
Yeah. So another team that we work with, I think this is one of a very innovative approach, where when they are hiring a nurse and the recruiter is interviewing them, they are not even trying to slot a nurse into a very specific role. They will create a role on the fly for that nurse if they're experienced and specialized.
Yep.
So that's also been really giving more autonomy to the HR and talent acquisition teams has also been helpful there.
This all seems like good things that can come out of a really trying time.
Yeah, absolutely.
Yeah.
Also, it's fierce competition that's also driving it. You just don't have a choice anymore. All right, let's talk about compensation. It is a big topic. Definitely, it's the fourth most common reason why nurses change jobs. It's still a hot topic around retention as well. And it's one of many considerations, of course, for driving nurse retention. Love to hear your thoughts on compensation and how to apply design thinking to nurse compensation too.
I would love to hear everyone on the call's opinions on compensation, because there's so much going on. I think you have to be competitive. A lot of organizations are doing things like hazard pay, bonuses. They're not doing base pay, right? They're doing a variety of things to enhance but not improve base pay. And you always have to be competitive in this market. I mean, that's just for real. But again, if you're not listening to the nurses, you might find that the money that you're spending on recruitment is bothering or not making your retained nurses feel valuable. Our CHRO, who is really dialed in, Dr. Charlene is really dialed in. She is thinking about commitment bonuses. Like if you're committed, you're going to stay, and what do those commitment bonuses look like? I like that for compensation, because the nurses talked to us and said, you know what, all this recruitment and sign-on bonuses, what about me? So again, it's that listening. And I also think that it's a really unique time for nurses to speak up and say what's important to them for compensation. They have to feel valued. It has to be competitive, but are shift differentials more important to them than hazard pay? Is charge nurse pay more important to them in your organization? Is paying for your education the benefit that they want versus other compensation? So again, I'm just really begging people to just listen to their unique workforce instead of just throwing the compensation out there, because I think the nurses will tell you what's important to them. And that's what we did. And we decided to go with commitment bonuses. We did some difference for charge nurse pay. We did a kind of an overall compensation lift. But again, that in and of itself, if you're not listening, you could be off base, you could be wasting precious funds. And then that has to be coupled with well-being and the environment that the nurse works in, because just giving more money to people who are suffering is not going to keep them forever.
Absolutely. And, to your point earlier, the sign-on bonuses and hazard pay are very temporary in nature. Whereas increasing base pay and potentially retention bonuses are long-term solutions.
Yeah, and I think you're gonna have to be competitive with both.
Yep.
You have to look at what your market is doing. And I think I love nurses in the conversation because nurses get that right away, right? They're like, that's nice, hazard pay, but my base pay is still the same. And if it's at the 25th percentile,
Yeah.
maybe I'm not happy with that. So I don't know that I would bother with that if your nurses were saying that. I think you got to go where they are going to think the value is for them.
Got it. I want to come back to something that you said earlier, because I think it's just really insightful around hospitals are paying nurses to suffer. Can you just elaborate a little bit more on that, around how the compensation is used as a solution for the burnout problem, but that's not addressing the problem?
Yeah, I don't want to be glib about women, about nurses suffering, because it's real. But I just think that if it's only compensation you're doing, and the nurses, you haven't listened to them, and you haven't let them be with you in solutions, and then they finally just start voicing very loudly, it's compensation, it's compensation, it's compensation, and that's all you're going to do. You're just paying them more to take away the sting of their suffering. And paying nurses more to suffer doesn't mean that they won't be burned out, and that they will be able to navigate their lives, and that they will be able to get through the next shift. And so I use that phrase here too. And it's like, let's not just do compensation and pay our nurses more to suffer. Let's work on their suffering and balance our compensation.
Got it. Okay. I'm just going to do a very quick overview of Incredible Health, what it is that we do for nurse hiring and nurse retention, and then we will spend the rest of the time on Q&A. And so for everyone on the call, please keep submitting your questions and your thoughts as we go through here. All right, so Incredible Health, we are a software company, a marketplace technology company headquartered in San Francisco. Hospitals and health systems, they use our custom matching technology to hire high quality permanent nurses at scale in less than 20 days. It normally takes 80 days or longer. There's a few unique things about us. There's, a few of them, four or five of them. Number one, the employers apply to the nurses instead of the other way around. As you can imagine, the nurses absolutely love that. They create a profile, they sit back and relax. They hear from different employers, and the nurse gets to choose which interviews to accept or decline. So this is a very candidate-centric or nurse-centric model. And we did apply design thinking in our case too. Listen to the nurses. And the nurses usually do not have a fun time when looking for jobs. I apply to 10, 15 places. I don't hear back. If I hear back, it takes months. There has to be a better way. So we really flipped it around for them. In addition, we have proprietary sourcing, screening, and matching. So we attract nurses to our platform in innovative ways. For example, we offer free continuing education to every single nurse in the country. We have free salary estimators. We have an advice network, and we're for nurses inside our apps. Again, that a lot of those ideas and concepts started with listening to nurses and what they want and what they're looking for. We also have proprietary screening. So we pre-screen and pre-vet all of the talent and all the nurses on our platform ahead of time before putting them in front of employers. And then for every single employer that we work with, we build custom matching algorithms. So it's a highly personalized experience. So let's say you are a recruiter at, I don't know, Kaiser Permanente or at Vidant Health, and you log in, you don't really want to see 200 nurses. You want to see 11 that are the exact right fit for you at that time. Same thing from the nurse's perspective. Let's say you're a highly sought after OR nurse or ICU nurse. You don't want to hear from 100 employers. You want to hear from 4 or 5 that are the exact right fit for you. And then we have tons of data analytics, which the HR and nursing executives love, and the CEOs love too, because it really shows how the speed of how nurses are proceeding through the hiring process, and because we work with so many health systems now, we have a lot of benchmark data and averages too that we can compare against as well. We are used by over 500 hospitals and health systems across the country. including very big ones like HCA and Kaiser Permanente and Baylor Scott and White. We work with many academic medical centers too, like Johns Hopkins and NYU and Cedars-Sinai and others, and lots of community hospitals. And so we are live across the majority of the country now. As far as what we do for nurse retention, one of the surprising findings that we had, when we started the company, we were like, okay, this is just going to be about nurse hiring. And then we started tracking and measuring, nurse retention, especially at the 1 year mark. And we noticed that nurses hired through Incredible Health had a 15% higher retention than nurses who were hired through other, traditional channels. And we dug into what were the reasons for that. Why is that? And a lot of it came down to the fact that nurses were able to consider multiple roles before selecting, Vidant Health, as an example. So it's a very thorough job search, and they're, as opposed to taking the first thing I can get. And so nurses are able to compare multiple employers more easily, and it's a very thoughtful job search, as opposed to just, hey, let me just take the first thing. The other thing is we notice is the importance of speed. I think when we started this company, we thought that, it's going to be the hospitals with the biggest brands that hire the most, or the hospitals with the highest compensation in the country would hire the most. And that is in fact not true at all. The hospitals with the best candidate experience, which is strongly correlated with speed, the hospitals are able to get nurses through their hiring processes efficiently, rapidly, hire the most. Data from our platform shows that 68% of nurses accept the very first offer they receive, and 61% of nurses accept their first offer that they receive, even if the second or third offer end up having higher compensation. We always say that hiring and the entry point for an employee is through HR hiring, interacting with their nurse managers too. That is the front door to the hospital and health system. That is the beginning of the employee experience. So when we create a strong employee experience in the very beginning, a strong candidate experience, that usually creates a very positive impression for the rest of the employee experience too. So we see a lot of data that shows correlation between strong candidate experience drives higher employee engagement too. As far as how we collaborate with teams, this is an example just from the Stanford team who we work with. These are the 8 steps of the hiring process. Everybody roughly has the same steps. We are doing a lot of the heavy lifting in the first 4 steps: the sourcing, pre-screening, making sure they're actively looking, getting that first phone screen scheduled automatically. And then the in-house talent acquisition team is taking over at that point, completing that phone screen, getting hiring manager interviews scheduled, getting offers accepted, the offer sent and accepted. So this is a true collaboration. We do not believe in outsourcing. We believe hospitals should have very strong in-house talent acquisition teams. We should try to get those talent acquisition teams and those nurse hiring managers some help by providing some software and automation to do the heavy lifting in these first 4 steps, because frankly, a lot of these first 4 steps can be automated. And that enables recruiters and hiring managers to operate at the top of their skill set, which is interacting and engaging with candidates and forming strong relationships with hiring managers. We want the recruiters on the phones talking to people, not doing a bunch of administrative work behind the scenes in sourcing and screening. This is the kind of data that we replicate for our teams. Essentially, we are tasked with reducing the days to fill from 60. This is an example of an LA team. We got it down from 66 days down to 19 days to fill. You can see the different steps of the hiring process. We have the biggest impact on the time to source, getting that down from 44 days down to 3 days because of the unique ways that we're able to acquire nurses on our platform. All right, so we'll pause there and go into Q&A. And just so everybody's aware, we have an email set up as well, questions@incrediblehealth.com. So if we don't get to all the questions or you have another question comes up after the webinar, please feel free to email us and we'll respond to you. And if it's a question for Julie, we'll ask Julie for an answer too. So we've got about 10 minutes left and would love to go through some Q&A here. All right, so there's a few comments that have come in. First from Shauna, when we say resilience, nurses here suck it up, that they want to thrive. I think that's a huge insight, Julie, that you shared with us, because all of us should be adapting our vocabulary in a way that resonates. And
they told us that
yeah,
just 2 weeks ago, they said, don't use that word anymore.
Right. So instead of resilience, you recommend
Yeah,
well-being?
commitment or thrive, we call well-being.
Thriving.
Yeah.
Yeah. Okay. Awesome. And then Brian Stanford also, he confirmed the use of the internal travel agency, creating nurse roles in-house where we pay them more for more flexibility. And that has been successful in eliminating travel agencies and using outside agency help, which is great. And then it's also better to be an internal traveler, right? Because you get benefits too. Brian also mentioned that they launched an internal RN retention program that includes additional pay for every 90 days. What was that? So with $2,500 pay for every 90 days for full-time RNs without a work requirement. Okay, it's awesome. Okay, this is a question for both Julie and me. This is from Shruti. Do you think hospitals are creating more flexibility for the nurse, like 6-hour shifts, for example, and giving them more options or more choice around their schedule?
I'm hoping that they all are and that we're all talking about it, because I think what we've heard today is that the nurses won't tend to come to you if you only have a limited option. So I'm hopeful we are, and I'm sure people on this could chat in and say if they were looking at that, but most people that I talk to, that's what they know, that's the work they have to do, is have different flexible shifts. What do you think?
Yeah, I mean, we are seeing it more and more across the country. However, there's still a lot of work to be done here. A very common inflexible situation that happens is, hey, we really need more ICU nurses. We want more OR nurses. However, we only have 3 days a week, 12-hour shifts. And by the way, we only have night shifts available for new hires. And all the day shifts have already been taken by all the internal nurses. That is not a recipe for attracting more ICU and OR nurses to the health system. So what we've seen, because very few people want to work a night shift. And I understand the preferential treatment for nurses that are already there. However, some health systems have instead adopted an approach where there is no such thing as a day shift and a night shift. It's a mixed shift. And if you are a nurse who's already there or a nurse who's coming in, you do have to do a combination of day shifts and night shifts just to keep it fair. And to attract more talent to the health system. That's, it is a contentious topic, frankly, because, there are nurses who've delivered on the loyalty and commitment to their health systems and therefore are getting preferential treatment on schedules. But curious if you had any thoughts about this topic, Julie.
Well, so it is contentious. And so even as you say it, I can feel my little nurse cringing a little bit. But I think that's, again, I'm sorry to be so like a, broken record, but if you talk to nurses and say, we can work short, or we can come up with some way that experienced nurses want to come here too, then you might get to a place that's a mixed shift that people, or a sign-on shift, or some rotation, or some on call that people will be okay with. I think this goes to that whole, you can't be just focused on recruitment. You can't be just focused on retention, but getting with the nurse and say, people won't come here if it's all night shifts. What are we all going to do together? What are you guys willing to do? What do you think's the solution? Because we can't attract people right now. And usually and if you make them do it, they won't like it, but usually they'll come up with something. They'll be like, yeah, we don't want to work short. Okay, so what is that going to look like? Yeah. Let them design it.
Yeah, absolutely. All right, the question from Jamie, I think this one's to me. What is the percentage of active versus passive job seekers on the platform? It's 80-20. So 80% are passive, 20% are actively looking at any given time. Honestly, that correlates very strongly with the annual turnover numbers that we're all seeing of 21%. So at any given time in the market, 21% of nurses are actively looking. And then even we see the same numbers on our marketplace as well. 20% are actively looking.
Do you ever have when people are passive on the platform that when it's the right job for them, or it'll turn, that they'll be like, oh, now that is something I didn't really know I was going to leave, but now I'm seeing this. Does that happen?
Exactly, it does. So when we think about active job seekers and passive job seekers, it's not black or white. It's not either or, it's a spectrum.
Yeah.
So you can be passive and like, starting to get active, and then, or you can be very, very active, right? And everything in between. And so what we have to do as a strategy is we have in place a very strong reactivation strategy, where we are able to remarket or reactivate nurses in our database by showing them roles that have been custom matched to them. And so even if someone was passive or not quite actively looking, they can be like, oh, actually, this looks pretty good. I would be interested in that. And so now they've switched from passive to active.
Nice.
We think it's on us. It's our responsibility to enable that transition from passive to active, and the other way around. If someone is done or no longer actively looking, it's our responsibility as a marketplace to immediately transition them to back to passive, because we don't want to waste anyone's time, and we don't want to. Hospital recruiter time is very precious as well.
Very good.
All right, Beth, getting a link to the recording. Absolutely. We will be sending out a link to this recording and to this webinar afterwards. Comment from Laura. I use the word flourish instead of thrive.
I love that.
And the organization as a whole does that too. This is Laura Atkinson.
That's good.
It's a great input. All right, question from Shauna for both of us. What efforts do you recommend to reactivate nurses who've departed, who left the workforce 2 years, 5 years, 10 years ago?
Wow. I think that, again, that's going to be one size fits one. I think you have to try a variety of things. I think there's non-traditional shifts and roles that you could try. I think if you're going to stick with your 3/12 nights, they probably won't come back. But if you have non-traditional roles or something that they can do to help, we saw that in the pandemic. People came back because they wanted to give vaccines. So let's build on that. You came back to get a vaccine. You gave vaccines in my clinic. Now, do you want to come and do a 2-hour overlap when the nurses are changing shift because I don't have as many nurses? So again, I think it's just about trying to figure out what are the things that would attract them back and asking them. Yep. We did it in the pandemic. They came back. Remember, they got their license renewed and they came back to the clinics. And so as long as they got their license renewed, they may as well just come right back to the hospital.
Yeah, absolutely. We saw an influx of nurses doing their continuing education, because we offer it for free in our apps. Yep. And cool. Which is needed to activate many different state licenses. The other thing is, the other data point that we have is in the last 12 months, 1.5% of nurses have permanently left the workforce, either through early retirement or they're just got fed up. They're going on to do other things instead. So we're all going to have to come up with a strategy to potentially attract that group back, because we can't afford to lose anyone permanently. Another question from Shauna is very provocative. What's a better title or description for a travel nurse? Right now, the term is a bit misleading and divisive, and it speaks more to the contractual relationship between the nurse and the employer. Curious if you had any thoughts on this one, Julie.
I love that question because I love the concept of lexicon, and lexicon is important. Mm-hmm. And many of us have travel nurses that stay. Yeah. And so how do you create an inclusive environment? Because if you give a travel nurse if you call a nurse a travel nurse, it's an in-group and out-group now, right? Yep. And then the patients have something in their head about that, and the doctors have something in their head about that. So I think that that's a very provocative question we should all be asking is, in this new norm, what are we calling the internal nurses at work, the international nurses? I mean, are we calling them international nurses? Because that doesn't sound very good. Yeah. So I think that's our next that's our next foray.
I don't think we have an answer for you, Shauna.
We don't have the right lexicon for our new norm yet. We haven't developed it yet.
Yeah, I mean, on the hospital exec side, we've heard premium labor, contract worker. I don't think those are any better. But yeah, they're absolutely.
I'm going to go down that rabbit hole now.
All right, fantastic. All right, for everyone who's on the line, please feel free to submit any additional questions to questions@incrediblehealth.com. Ali, if you have a moment, you can also share our LinkedIn and our Twitter, and that's another way to submit questions too. And please, feel free to follow us on Incredible Health on Twitter, on LinkedIn, on Facebook. And we have a speaker series. There's another one tomorrow with Stephen McDonald, the VP of Talent Acquisition at HCA Healthcare. And we consistently do those every single month. We bring great speakers like Julie to share their insights and their thoughts on top of mind topics like nurse retention and nurse hiring. So thanks everyone for joining, and we'll be in touch with the recordings and so on. Thank you, Julie. Really appreciate your time as well.
Thank you for inviting me. Thanks, everybody. Never waste a good crisis. We got disruption to do. See ya.
Awesome. Thanks, Julie.